You know you're getting older when every outing starts with that one important question: where's the nearest washroom? Bladder leakage affects up to 3 out of 4 older women, and yet it's one of those topics that people would rather whisper about than talk about openly. Many of us just shrug and say, well, I guess that's just aging. But according to experts, we don't have to put up with it. And staying silent could be keeping people from enjoying the activities they love. I spoke with Dr. Adrian Wagg from the University of Alberta about why so many older adults accept that incontinence is inevitable and what can actually be done about it. Starting off with our discussion on urinary incontinence amongst older adults, do we know how common it is?
Yes, we do have a lot of information across many populations about how common incontinence is. More common in association with aging in women over 65, up to three out of four women, and up to 1 out of 12 men.
3 out of 4.
It depends on the framing of the question. Um, uh, Certainly in terms of yeah, how long you might have you been incontinent in the last year, and obviously the estimates increase with the width of that duration. So they are that's where you get so many different and variable estimates. But if you said, yeah, up to 3 out of 4 women over 65, 1 out of 12 men, that would be reasonable.
When does it normally start?
Normally, it's never normal.
Yeah.
And that's an important point actually, because it's a common misconception that incontinence is a normal part of getting older, particularly again amongst older women. Our studies in Albertan older women give that same 3 out of 4 women, and they still think it's normal even if they're leaking twice a day and using up to 2 pads a day. That didn't change their opinion. It's not a normal part of aging, and that's an attitude which is, as we said, held by a lot of older adults, but also, unfortunately, by a lot of care staff and clinicians.
So, if not a normal part of aging, what is it?
So there are multiple reasons for having accidental bladder leakage, which get more complicated and multifactorial in older adults. Certainly in midlife, you can categorize the majority of incontinence due to a disorder of urinary control. And we typically have stress incontinence or exertional incontinence, urgency incontinence, and then mixtures of the two would account for the majority of the problems. As one tends to find that older people have more things wrong with them, different areas of disability or problems with function, then those things load in too. More diseases, more treatments for those diseases, and physical impairments often interact and result in incontinence. Certainly in very late life, the triad of mobility impairment, cognitive impairment, and incontinence kind of go together, and it becomes as much a brain problem as a bladder problem. And there seems to be a linkage between diseases of the brain which result in incontinence.
Oh, you're right. It's definitely multifactorial when you mentioned all those things tied together. Um, when you mentioned it's an issue of the brain, um, how how much of it is the brain versus the physical thing? I guess that's a
Um,
physical thing too, but
Again, there are you're right. It is a physical thing. So those four pillars in very late life of comorbid conditions, uh, cognitive impairments, functional or impairments, and then medication problems are the four kind of areas that a clinician should look into thinking about attributable causes, in addition to simply lower urinary tract disease.
to some extent, is it not associated with aging because people don't have typically have these issues when they're 20?
Well, that's right. It's associated with. That doesn't mean that age is a cause of. Different.
Right.
It's more common in older age, but it's not normal for older age because if it was, everybody would have it.
Just true. And then in terms of how it affects people's lives, what kind of impact is it having on older lives in terms of their, ability to get out?
Yeah, incontinence and lower urinary tract symptoms is often kind of dismissed as a lifestyle or a hygienic problem, but actually there's a profound impact on quality of life and well-being. You mentioned people tend to go out less, isolate themselves, take less exercise. There's an increased risk of fall and fracture, an increased risk of mood disorder, increased risk of skin problems and urinary tract infection. So there's a broad number of consequences which are often almost sometimes overlooked, which is a shame. So it's never a high priority problem, and particularly because it's quite complicated when people go to their family doctor. They get a bit of the thing, but maybe compared to their heart disease, it's never so important to do anything about. And then people themselves with the problem, there's an awareness of the availability of treatment problem. There's this thing, I'm older, so this is what I should expect, and it's often not brought up with the doctor or clinician because it's not that important to bother the clinician with the problem.
But what a tremendous amount of cascading effects, like you mentioned.
Yes, and in many of the um, diseases of later life, particularly in terms of multimorbidity and frailty in older adults, incontinence is writ large. But incontinence is often a not a priority for managing, even though when you do manage it and you can ameliorate the symptoms, there's a huge impact on well-being, and that's well demonstrated.
Okay, so when should a person bring this up with their doctor as something they go, like, some person might think, oh, it's just a small
Yeah,
inconvenience. When should they bring it up to the doctor?
so if you've got it and it bothers you, but then again, there's a problem there because if it doesn't bother you, does that mean it's acceptable? Because you got people adopt. It's like a thermostat. You get used to the new temperature, so you alter your lifestyle and behaviors to accommodate with your incontinence. You have pads in your purse, or spare clothes, or you wear black, or you don't go places, and that then becomes normal. So it then doesn't bother you. But if you look from the outside, that's clearly not a not normal coping, and has a measurable impact on your well-being. So I would say, as soon as you have symptoms, and don't hold back, people probably need to advocate for themselves as much as they should with sexual health problems, because the taboo and the stigma and the social mores of not talking about bladder and bowel problems sometimes held by the doctor too.
So what can be done? You go to your doctor. What can you
Okay.
expect?
So there are lots of kind of things online or materials available where there are symptom sorters and checklists. You can arm yourself with those and say, look, I've got these symptoms. What can be done about them? I'm finding them bothersome. They're interfering with my life. And there are lots of, so you can arm yourself and advocate for yourself.
Um, in terms of, I've read a number of actions people can take, ranging from exercises. Let's first of all, how effective are the exercises that we hear about?
Okay, so it depends on what kind of exercises. Certainly for most forms of lower urinary tract and bladder symptoms, pelvic floor muscle therapy is the first line behavioral treatment that's often recommended. Better when supervised by a trained pelvic floor physiotherapist. You get a better response. Needs 4 to 6 months of work, will be very effective in 80% of cases. Um, and then combined with other lifestyle modifications, you can add to that. Pelvic floor exercise is the primary treatment for exertional or stress incontinence, but can be used to help with urgency suppression.
And you mentioned that it's best done under the supervision of an expert. You don't recommend just going online and looking up these
Uh,
exercises.
They are effective when done alone, not as effective as under supervision. Two reasons, I suspect. They're fairly easy to do in any situation. They're also very easy to forget. Having a personal trainer allows that individual to adjust the type of exercise and the frequency to your ability. And there's also the guilt factor. If you're going to see your personal trainer, you're going to go and do it. I think that's fairly important. And there's also, of course, there's a lot of guff online. and misinformation rather than disinformation, and then having the uh, critical faculties to judge whether what you're seeing and viewing is reputable and credible is important because there's so much stuff out there.
That's a huge point. I'm glad you made that. And in terms of the length of time, you're saying up to a half a year. So a person would have to make that time commitment for this.
Yes, and they're long-term incremental changes. There are various quick fixes being marketed around the province at the moment, for which the evidence is less than substantial and the personal cost can be high. And there is, if you can contract your own pelvic floor, uh, there is no substitute for doing those yourself.
The hard work pays off, I guess.
Unfortunately so, yes. Like
Yes.
like most exercise. So there are also data around good research evidence around just musculoskeletal and exercise, even for those people who are troubled by getting up multiple times at night, for example, a 30-minute walk each day has a meaningful impact on nighttime symptoms and also helps with your heart disease risk and general physical fitness. So exercise per se has been shown to help in even frail older adults in nursing homes through to community dwelling older adults.
Is there anything that movement can't fix?
Uh,
It really is
it's
amazing.
increasingly unlikely as far as the evidence accumulates. Yes, keeping
Yeah.
physically fit for as much as what you're able is clearly at the core of many interventions with multiple um, benefits.
You intrigued me when you said there were a number of, you didn't say sketchy, but the um, questionable treatments floating around right now. Can you mention some so we can warn people about them?
Um, it's again, it's difficult because there are so many sources of information. And I think what is rather important that the person looking it up has a very critical eye on the evidence source, the is the individual who's promoting the exercise reputable, credible, has a history of this kind of thing? Is what they're promoting, has it got some evidence behind it? And you can go and look to see if that is true. Particularly, say, there's a group of exercises called hypopressive exercises, which are often advertised as being helpful for incontinence, for which there is evidence of no benefit. Yet these things are still practiced and promoted in some quarters. So knowing where to go to find out if what's being talked about is helpful is always important. But that's promoting general health literacy, which is really important at any age.
If you hear it from Dr. Wagg at the University of Alberta, you know it's the
I'd
real
like to
deal.
think so.
You mentioned lifestyle changes. And you mentioned the exercise, the walking. Anything else that we should keep in mind?
Certainly in terms of urgency, urinary urgency, this sudden out of the blue feeling, oh my God, I've got to go for a pee, I can't hold on. Some fluids appear to make those symptoms worse. Caffeinated beverages and fizzy drinks, bizarrely, and alcohol, particularly late at night, because it disrupts your sleep and causes you to pee more. But again, there's a lot of guff about fluids and foods, which isn't for which there is evidence of no impact, but yet it's still in the common parlance.
So there is a link between carbonated
Yeah, for
drinks.
some we don't know why, whether the carbonated beverages do something themselves, and the data come from one medium-sized study in the UK, or the high intake of carbonated beverages is a signal of different dietary and nutritional habits that is that also is associated with a more risk of incontinence. So that triad of low physical activity, obesity, particularly obesity around the center of the body, has metabolic changes, which makes urgency incontinence and overactive bladder much more likely. So there's this thing about a bladder-brain axis that is affected by your metabolism and obesity, and of course then diet. Um, the the very processed Western diet would be part of that.
Okay. Not to dwell on that too much, but I know that people, often have those soda streams at home. So it's not the sugar, it's the carbonation. And we don't know that there's an exact link.
Yeah,
It,
it
it
appears to be something about fizzy drinks, but it's quite high levels of intake. And clearly, what most of the clinical guidelines say is try reducing those if you've got high intakes. If it works, grand, stick with it. If it doesn't, then there's probably no harm in continuing. So one or two coffees a day or one or two fizzy drinks a day may not be a problem. But there are people, as we know, who drink liters of things. So in addition to the volume, there's the type of fluid as well.
exactly. And then surgery. How often is surgery used as a
So
as a solution?
um, if conservative and pelvic floor muscle therapy fails for exertional incontinence, then there are a variety of surgical interventions which are effective. And certainly it's good to have go through your conservative measures first to delay or avoid surgery. But in some cases, a shorter move to surgery, particularly say in later life when cure isn't wanted, but making things better is a good thing. A minimally invasive procedure, for instance, you can inject stuff into the valve at the bottom of the bladder to tighten it up and to reduce leakage for that urgency incontinence. Should behavioral therapies and medications fail, then we're using onabotulinum toxin, Botox into the bladder, which is effective in about 60 to 70% of people.
And that still falls under the surgery
Yes, the
areas, the
surgeons do
Botox.
that. Yes. And so all the way from the injectable therapy through to more invasive procedures. So the tapes and slings for stress or exertional incontinence, and the implantation of nerve stimulation devices for urgency incontinence.
Is there any drawbacks to the Botox treatment?
The major adverse events associated with Botox, if you don't get the dosing right, is an inability for the duration of the Botox to effectively empty the bladder, which at its worst has to be managed by teaching people to pass a tube. And for some reason, an excessive urinary tract infection, but that's manageable by antibiotics.
Okay. And the more invasive surgery, how often do you see that procedure?
We
Is it very common?
So we obviously send quite a lot of older adults to our urogynecological colleagues and work with them. They're the surgeons that do these kind of operations all the time, so good results. And certainly for incontinence in later life, we know that the number of procedures has been falling. And we're not quite sure why, but 20% or so from the top of my head.
Is there a message you would like to get out to older adults who might be starting to experience some of these symptoms or have for the number of years?
Uh, in 3 lines, it is not normal. You do not need to accept it. There are treatments available that can make your life tolerable without having to put up with your symptoms.
That's exceptional advice because I know so many people who are to the extreme, like they won't go out, they won't come hiking with us because yeah, no, I
Yes. Yeah, and anecdotally, about a year or so ago, I saw a pastor's wife who's every Sunday she used to go out with her husband on his circuit of churches. Couldn't do that. Managed her incontinence, transformed her life. So you can, there were about 50% of people are very realistic in what they want to achieve. They wanted to get sufficient control so that their symptoms do not affect their daily life. And I think that's very fair. And for the majority of individuals, we can do that.
that almost sounds like a miracle cure. Just
Well, it's
so
not
many
a
people.
yeah, not a cure, of course, but
Yes, but it is to
yeah,
say
if
that
it has big impact on well-being and quality of life. Absolutely.
a
You don't
huge
you don't have to put up
impact.
with it.
Yeah. Have we seen any changes in research or in treatments in your research since you've been doing this?
I think yes, certainly we now have reasonably effective medications for urgency incontinence. we're seeing a diminution of those newer drugs, but an increase in the number of devices and bits of kit to manage incontinence. Some of which, unfortunately, we don't have in Alberta. But we can. There are some workarounds around. You can stimulate the nerves around the foot using a TENS machine. And we ask people to buy their TENS machine and teach them how to use it. So if the drugs don't work, that's an alternative to surgery. And then there are implantable stimulators which go near the foot, which are available. Again, not yet available here. So the clever bits of kit are improving.
Huh. And where would one have to go to get that
Um,
foot
uh,
stimulator?
a knowledgeable clinician can help with
Okay.
a patient-provided TENS machine to get that going for urgency incontinence. The implantable ones here are still not on the list, and that's
Mhm.
uh, in development. More advanced things are available in big centres under the auspices of the functional urology surgeons and urogynecologists,
Hmm.
and also
And
work for bowel leakage. So we have a couple of colorectal surgeons in our big cities who are working with what's called sacral nerve stimulators.
that's a whole fascinating field. I'd love to talk more about that at another date. I had heard that constipation may play a role. Is that correct?
Yes, certainly a bottom full of poo makes your urine, your bladder symptoms worse. So part of that initial assessment and workup is to manage constipation. And certainly it does help with some bladder symptoms.
All right. And in terms of the surgeries you mentioned, do you know if those are covered?
Covered. Yes. All of those things, other than the implantable peripheral nerve stimulators, are covered. The problem we have, of course, is the access and waiting times. There are too few surgeons for demand.
Right. Do you know what a typical wait time would be to access that type of surgery?
I couldn't tell you, obviously, across the province, but our local lists are, sometimes in excess of a year
Right.
or two. So not
Anything
to to
else?
do all of those lifestyle and conservative
Yeah. Yes.
to see how
That's
we can get out of those first.
that's very, very true. You have the year to do your exercises and the lifestyle changes. Anything else you would like our audience here to know that I might have missed?
Um, Find yourself a knowledgeable healthcare provider. Ask your family doc if he's not sure. And a lot of family doctors are entirely competent, but not confident because they often don't see enough. And there are now a reasonable scattering of services who can provide that help. Most physiotherapists don't require clinician referrals. It's always a good step to go and get an assessment. And in Edmonton, particularly, there we have three or four different continence services which are multi-professional.
Because right, we can't depend on our family physicians to be experts in all things. So your first line would be you go to your family doctor and they would likely send you to a physiotherapist for the
It,
exercises.
it's a good gateway, absolutely. And I think I've sat in meetings with a lot of my fellow specialists say, oh, well, this is a primary care problem. But yes, all of the specialists are saying exactly the same thing. And the family doctors have a considerable workload and lots of things to deal with.
Mhm. Wonderful. This has been so informative and to so many people. I really appreciate your time. And I'm looking forward to chatting with you at another time about your specific study on incontinence in long-term care facilities.